You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is June 29, 2012, and I'm your host, Dr. Jay Portnoy. Our topic today, patient adherence. Our presenter is Dr. Christina Duncan. She's an associate professor and coordinator of the Clinical Child Psychology program at the West Virginia University in Morgantown, West Virginia. So we're joined today by Dr. Christina Duncan. Dr. Duncan spent a few years here at Children's Mercy Hospitals and Clinics. She's a psychologist, PhD, does research, and her interest is in adherence, which is something that all of us find to be really important. We can see patients, diagnose them, recommend treatment, but if the patient doesn't actually do the treatment, it's not very helpful. So finding out why patients sometimes take their medicine or don't take their medicine or follow treatment recommendations, that's a whole area of interest that Dr. Duncan has been a very important contributor to. So we're really glad that you were willing to come and join us this morning and talk to us about adherence, which is something that we really just need to know more about. So I've got Dr. Duncan's slides on our computer. It's a very slow computer. There it is. So Dr. Duncan is an associate professor, and she's the coordinator of the Clinical Child Psychology program at West Virginia University, which I've been told is not the same as Virginia. It's West Virginia. There's no East Virginia, is there?
No, there's not.
Okay, there should be. Be balanced that way. Okay. Anyway, so welcome to Conferences Online Allergy, Dr. Duncan. Thank you for joining us this morning.
Well, thank you for having me and for giving me the opportunity to talk about something that's near and dear to my heart and something that I enjoy doing work on, and that's adherence in pediatric asthma. So if you want to go ahead and go to the next slide.
Certainly.
Just to provide a little overview of the talk, I'm going to start out talking a little bit about defining adherence, and then also kind of move into some developmental trends in adherence with pediatric asthma. And from there, we're going to talk a little bit about some barriers to adherence in pediatric asthma, because those are really important for us to understand as we try to conceptualize where our families are coming from when it comes to following the treatment plans that we recommend. Then we're going to talk about all the different methods for assessing adherence and hopefully provide some practical tips as well for how to improve using those methods or how to incorporate those methods into your clinical practice. And then finally talk about some interventions to improve adherence. Just as a caveat before I get started, this could be easily a half-day, full-day session, so I'm only going to really hit on some of the high points and hopefully leave you with at least some tools or some messages that you can take with you in your pocket. That's the goal of this presentation today. So next slide. So research has actually produced a great deal of information about factors associated with non-adherence, but there's actually been little progress in terms of how to modify the behavior. So if you look at the literature, indeed on average, whether it's children or adults, they typically take about 50% of their prescribed medication. And that's across different disease groups and is certainly not unique to asthma. However, there are various patient factors that have been found to be associated with non-adherence. And this problem actually occurs in both genders, across all ages, races, socioeconomic status, and disease groups. So some researchers have actually argued that the apparent lack of progress that we've made with medical non-adherence stems largely from the perspective that we've been taking. Specifically, what they argue is that we need to take more of a patient-centered approach when we understand non-adherence. And what I mean by that is when you have this approach, you consider the patient as being someone who's actively involved in their care and also in the decisions about their care. You view yourself as a provider as really an expert consultant and a teacher. and that's your role in the context of decision-making and treatment planning for the patient and their family. And then having a relationship that is really more collaborative and interactive with the patient and their family rather than seeing the provider as more of an authoritarian individual. And then one of the really key elements, I think, in this patient-centered perspective is really to think about non-adherence as not being unusual or being deviant, but something that's really to be expected, given how frequently it occurs and given some of the factors and barriers that lead to it, which we'll talk about a little bit more. Next slide. By the way, feel free to stop me if you have any questions along the way.
Yeah, you mentioned the collaborative relationship. Is that what differentiates adherence from compliance, for example?
That is one of the reasons we use the term adherence as opposed to compliance. There's sort of this idea that compliance is a pejorative term, and it's suggesting that the physician or the provider is the person who's, you know, in an authority role. And
to go on some of the examples of non-adherence we have here on the slide, as mentioned a little bit earlier, that adherence is really a diverse set of behaviors, and so some common examples, though not an exhaustive list, actually appear on this slide. So things like just failing to take their medications properly, taking an incorrect dose, missing clinic appointments even is considered a behavior within the realm of non-adherence. Next slide. So there are certain developmental trends in adherence to pediatric asthma, and in particular, research has shown that non-adherence to asthma regimens increases as children age. And this really isn't surprising because adolescents tend to prefer more autonomy, and at times they can actually perceive their parents' help as being intrusive or annoying when they take part in terms of prompting or playing a key role in supervising their child's regimen. So what happens is that parents often decrease their involvement in their child's asthma care as their child gets older. And actually, if you look at the literature, the average age for when parents tend to shift over that responsibility is when children are about age 9. So when we talk about adolescence, you really have to back up a few years because it's really much younger children that are oftentimes given the responsibility solely to take care of their asthma and to remember their medications. So it's certainly down in the school age range for children. So this increased parental involvement may be due to a number of reasons. For example, parents may incorrectly think that their child is capable of managing their asthma on their own, or parents may be encountering stress in their day-to-day life and it's just simply easier to give that responsibility to the child. And there may also be just more conflict. For example, we know that as adolescents get older, the parent-child relationship tends to have a little more conflict than when the children were younger, and just kind of stepping back and not being as involved in asthma care can be an avoidance strategy that parents have just in general with their relationship with their adolescent. But it's important to note that parent involvement in supervision is typically related to higher adherence on the whole. So it's something that we really need to consider as an important target when we look at how to promote adherence in our families. It's important to note, however, even though it's one of my areas of interest, there's really been little research that's been done to look at when and how to transition that responsibility to youth so that they can be adherent and conflict doesn't necessarily increase, and certainly get better health outcomes as well. Next slide. So another important area of research that's been going on for some time and informs a little bit of what we think from working with our patients is looking at what are the different barriers to adherence in pediatric asthma. And it's important to note that these barriers can be very unique to each family. And they can have multiple barriers. They can have one very significant barrier. But it's important to think about these when we talk with our families because these can certainly be the obstacles that get in the way of them following treatment plans as best as they can. So one of the first ones is the difficulty and disruptiveness of the regimen. Adherence actually seems to be related more to regimen factors than to patient characteristics. And I know that's kind of probably counterintuitive to some of our clinical experiences, but the research really does pan out that it's a lot more related to the regimen and its characteristics than the parents or the patient characteristics in general. So patients may decide that some kinds of treatment regimens are too much trouble, they're too hard to do, maybe they're too intrusive, or they affect their lifestyle and their activities in a way that they don't want that to happen. So that is certainly one area we need to think about. Another area is the patient and family characteristics. And though it's not as strong as a relation to adherence, there has been a pretty consistent body of literature that has linked certain characteristics to higher rates of non-adherence. Things like dysfunction within the family, so the child having higher behavior problems, the parents having higher mental health issues, and there just being overall family dysfunction has been related to higher non-adherence in asthma. Stress within the family unit, lack of social support and resources, as well as a lack of routines. Actually, there was a study that looked at families who had higher routines in their home in general were more likely to refill their prescriptions, for example. And then, of course, there's developmental issues with the children. So we already talked about adolescence and what that brings with it, but there's also challenges with very young children, getting them to sit still and to complete their treatments when maybe there's some typical 2-year-old tantrums and oppositional behavior, for example, that comes into the mix. There are also provider and system factors. There's been a good bit of research to show that the relationship between the provider and the family and the quality of that relationship is important for adherence. We'll talk about that a little bit more. But overall, when patients are dissatisfied, it's been shown to be related to lower adherence rates. Next slide. Another area of barriers to look at is the patient beliefs, fears, and concerns. Certainly if a patient or family denies a diagnosis, they're going to be less apt to buy into a treatment plan that's prescribed for that diagnosis. So that is something that needs to be explored with families. And if you have that open line of communication rather than more of an authoritarian style, families may be more comfortable or feel more comfortable sharing their beliefs with you. There's oftentimes also misunderstandings about the illness. Can kids grow out of it, for example, or thoughts about medication, you know, that steroids are the same as anabolic steroids, for example, and that can certainly come to play a role in the decision making. And we have to remember that some of our patients function within a broader family unit as well. So you may have the parent and the child believing that these medications are safe and appropriate to use, and then they go home and the extended family, a grandparent, for example, may change those views based on some of their misunderstandings. So it's important to understand that as well. Part of this has to do with how families and patients perceive their medications as being effective and whether they have side effects as well. And simply being motivated. Do they feel enough disease burden, for example, to really take medications on a regular basis? Other things like social barriers may affect their, maybe a fear that they have. I've had adolescents, for example, who don't want to use an inhaler in the football training room because, you know, the buddies give them a hard time. So recognizing that that's an anxiety or a fear concern that they may have is certainly a very important point. I think it's interesting, actually, we think of like low SES and minority families as being higher risk for non-adherence, and they are with asthma, but there was actually a study that was done with low SES African-American families, and they found that it's the parents' health belief that actually was the most significant obstacle to adherence rather than financial constraints or health system constraints, which is what we typically tie to SES as a risk factor. So I think we really need to pay good attention to this as an area of concern.
But even so, what effect does the cost of the medicine itself have on adherence? Because it's expensive and you have to choose between taking an inhaler and putting food on the table. Isn't that a significant issue as well?
Certainly it is, and in some families you've got to figure that out. But what I meant by that study that I think is interesting is we automatically think low SES families don't take their medications because they can't afford it. And if that's the tactic we're going with, we may not be successful when in fact it could be a health belief rather than a real financial constraint. So it's really important to get to understand that. And actually in my research I've started to include health beliefs a lot more commonly in the studies I've been doing, and almost always it comes up as a significant predictor. So again, I think it's an area we really need to pay closer attention to and recognize that our relationship with families is really going to be the mechanism or the medium through which we can get to understand our patient and family's beliefs and to address them in a satisfactory way. Another barrier that is unique, I think, to asthma, maybe some other diseases as well, is the symptom variability with asthma. And maybe this helps to account for non-adherence in mild asthma because it ties back again into these beliefs of maybe I don't need my medication. You know, there's not a direct stimulus-response relationship with medication and asthma exacerbations like you might see, for example, in diabetes. So a patient with asthma can use their preventive inhaler and still have an exacerbation that day. Or vice versa, they can skip a couple days and maybe not have an exacerbation. And so there's not that one-on-one relation between using medication as a stimulus and then an exacerbation as a response. And that can lead into some of these other factors as well with non-adherence. Next slide. So keeping that in mind and thinking about beliefs, I think it's also important to recognize that there really are two types of non-adherence. There's what's referred to as inadvertent adherence, which is when patients accept the treatment advice, but for various reasons they don't adhere to it. You know, maybe they miss medication because they're forgetful, or because the child has multiple caregivers and the communication breaks down. Or maybe they just have to rush off to work in the morning and it's simpler to just miss a dose here or there and not be late for work. But overall, their beliefs and their attitudes about the disease and its treatment are on par with the provider. Other aspects of that can be when people have inadequate instruction, or maybe they misunderstood the instructions that were provided to them. So it's not that they don't want to adhere, it's that they didn't understand it. So, for example, I had an adolescent in one of my studies who was, in her mind and in the data, looked to be 100% adherent, but she was actually 50% adherent because she would discharge 2 puffs of her inhaler and then inhale, rather than inhaling after each of the puffs. And so she was 100% consistent with that approach, but obviously was not adherent at the level that was expected. This is where a lot of our interventions are targeting and assuming that most patients are just inadvertently non-adherent. But as you all know, there's a portion of our population that would fall under the category of volitional non-adherence, and this is an area that I'm very interested in, and actually became most interested when I was there at Mercy. This is when the patient and family, they understand the advice, but they make a reasoned choice not to adhere. So their treatment goals might be different. You know, their goal might be to minimize their medication, whereas the providers might be to follow guidelines. It might be that lifestyle situations prevent the acceptability of the treatment plans that's prescribed. And I'll bring up a case in a minute or a little bit later that I think is a great example of this. Or going back again to the belief about health and medications, and that interferes. So I think this follows nicely from the discussion of health beliefs, because when we look at volitional non-adherence, beliefs are a big part of those decisions that they make, which are purposeful, reasoned decisions to alter their treatment plan in a way that then makes it more acceptable to them. Next slide.
So they don't always, sometimes I'm interested that they might even deceive the provider about making that decision. So you ask them about it and they don't tell you the truth. Is that very common?
Exactly. Yes, exactly. It is very common. And again, this goes back to the importance of establishing open and honest communication with your patients and families, and making them feel comfortable about sharing their concerns and their perspective. So getting to that, let's talk about some methods for assessing adherence. The first method that's oftentimes used is health status. And this seems intuitive because our ultimate goal for adherence is for our patients to improve their health status. But this is actually not a very good measure for adherence because it's not interchangeable. As you know, somebody can be 100% non-adherent and have no health problems, and a patient can be 100% adherence and have significant health problems. So it's not always interchangeable. Ratings by healthcare professionals have also been used, but we'll look at the research literature. Those two are often wrought with problems. They're often based on self-report of the patient and family, which we're going to talk about in a minute, or the health status, which we just talked about as being a concern. And then there's also the potential for bias, that providers might consider other factors that they know about the family and make assumptions, for example, about whether adherence is good or bad. Next slide. Pill counts and canister weights are another method for assessing adherence. They're certainly more objective, but they still also have a potential to overestimate because you don't have any proof that the pills were ingested, for example, and some studies have actually shown how a lot of patients will actually dump the medication out of their inhalers by discharging them multiple times before coming into clinic. So if they're just dumping the medication, we don't always know based on just weighing the canister as to whether that medication was inhaled as well. Now, electronic monitoring devices are a way to kind of counteract those disadvantages for using pill counts and canister weights. This is when you attach a computerized device for counting pills or for discharging the asthma inhaler, or maybe even inhaling it. Some of them detect inhalation. There's also electronic monitoring devices for peak flow meters as well. And when we gather data from these devices, we're able to get a more continuous and detailed record of adherence. You're able to find out if somebody dumped their medication before coming in for an appointment. So there's a lot of pros for using electronic monitoring devices. You know, you can use them as an outcome in intervention research, which is something I do. You can use them as feedback as part of an intervention. In some of the treatments I'm using, I'm having families actually use them to help promote that responsibility in use, but still maintain some level of parent involvement. So really, they do have a lot of potential, but on the negative side, they are expensive. They can also be fairly technologically complex, so in a fast-paced clinic, that may be an obstacle or a barrier. Patients don't always return their device. Sometimes they do things like run over them, put them in the washing machine, things like that. And like all high-tech devices, as we've learned today, they sometimes malfunction. So certainly there are concerns in using electronic monitoring devices as well, but there are a number of them available now, and certainly could be an opportunity to explore, particularly with those patients who have very severe disease or viewed as frequent flyers in terms of healthcare utilization as well. They may be a nice alternative. Next slide. Behavioral observations is another way of assessing adherence, and this is really important when we teach, but it's also an area that we should be reassessing. And typically in our area, it's when we're looking at skills for using inhalers, various inhalers or nebulizers or peak flow meters. So making sure that that skill is there is something that is an important part of assessment as well. So that child that I spoke of that took discharged 2 puffs and then inhaled, had she been observed in clinic, that may have been caught. So that's something to consider. Self-monitoring, or asthma diaries as they're often called, has been used in the past, but research has pretty much found that they are not real positive for measuring adherence for a couple reasons. One, you know, they're really a significant potential for last-minute completion and to falsify data on them. But also, too, if you have non-adherent families who don't take their medication, then they're probably not going to be very adherent at writing that down. So they're not always a good alternative to consider, but they are certainly one that you'll see in the field. Next slide.
So I'm worried about the way the mom is using the inhaler on her child on the picture you're showing. It looks like she's just going to swallow it instead of inhaling it.
Yes, and there's no spacer device. So you should see, if you Google images, more images than not are improper technique. So pharmacy refill data. This is actually an area, I don't know if y'all use it too much in your clinic, but I've seen it being used in other clinics. And it is an objective measure. Again, it doesn't guarantee that the medication was actually ingested or used, but you can get a base adherence estimate on the prescriptions that are filled, and from there indirectly infer whether the patient is following their regimen and how closely they're following it. It does take extra personnel, and it does take some time. Pharmacies, I will tell you, are not always cooperative. We use it in our research, and certainly it's not very easy to use from time to time. But once you sort of get it going and you get to know the pharmacies that are in your area, it certainly is an area that can be incorporated into practice. And it's a way of getting a more objective measure, though indirect, of adherence.
I think we're getting close to being able to get access to this kind of information, and it'll be interesting to see how it changes the way we take care of our patients.
Yeah, and I think it is challenging. You bring up a good point. So you go get this pharmacy refill data, and your patient just told you that they're 100% adherent, and you go get the data, and it's horrible. How do you present that information? I've seen some providers present it in a very negative manner where I've had to go back and kind of clean up behind them. So it is a challenge, and you have to work with that and practice on, again, how am I going to maintain that positive, open communication relationship I want with my family, but here they told me one thing and I found out another. How am I going to present that to them?
Well, on the other hand,
and it's an art.
I was having a conversation with a pharmaceutical rep yesterday, and of course we know what their motivation is, and they were talking about if you refill your albuterol canister 2 times a year, 2 canisters a year, that you're uncontrolled and need to be on daily anti-inflammatory medicine. I pointed out most people get 2 of them so they can keep one at home and one at school, and it expires after a year, so you have to refill it even if you never used it. So, but it's being misused. The information is being misinterpreted with, ulterior motivations.
Exactly. So just keep in mind, though, that if you do decide to use pharmacy refill data, that it can actually under or overestimate adherence. So you don't know if patients are taking all of their medications. For example, just simply refilling the prescription doesn't necessarily mean that they're taking it, which can underestimate adherence. But on the flip side, as you sort of mentioned, Jay, is that patients may stockpile medications, or they may take one of the other family members' medication, not ideal, but it happens, or they may have samples that are available to them. And so just because they don't refill their prescription also doesn't necessarily mean that they're not taking the medication. So we have to be careful in how we interpret that. Families may use...
I don't mind them sharing pills so much, although they shouldn't do that. I draw the line at nose spray, though. Don't share nose spray.
Definitely. But keep that in mind. Keep in mind that families may use different pharmacies as well, and there are other factors such as, the cost of prescription, things like that can compound your data. So just keep those things in mind. Next slide. Then we come to self-report, which is probably our most frequent method of assessing adherence in our patients. It's easy, it's inexpensive, you can ask it of anybody. But we have to recognize that it's usually very biased, and the research has been consistent in demonstrating that. So when we look at self-report, it's usually an overestimate of adherence. So for example, there was a study done by Bender and colleagues that found that mothers reported adherence rates at 88%, the children were reporting 83%, but when they monitored it objectively with a dose or CT, it was actually 55%. And that's just one study. There are many, many studies that show that patients tend to over-report adherence. And that probably stems, again, from the social desirability and the relationship maybe that is there between the provider and the family. If a patient, however, tells you that they're not taking their medication, you can pretty safely assume that they're not taking their medication. That's something to think about. Next slide. So how can we get more accurate self-report? If this is one of the areas that we're wanting to use, it's convenient, it's a method of assessment that's helpful for us, how can we get more accurate self-report? Well, one of the tips I'm going to share with you is first to use a brief interval for recall. Don't ask them over the last 6 months. Probably not even good to ask over the last month. So think about what the prescribed frequency is and ask within, say, the last 24 hours, if it's a very frequent medication. If it's a once or twice a day medication, you can probably ask over the past week. And then maybe ask them, well, was last week much different than any other week? And that gives you an idea if you need to ask further. But you really want to keep your intervals pretty brief because we just don't remember things that long. You also want to be specific with the information that you request. So don't just say, how often do you take your medication? You want to ask them about each of their inhalers, their nasal sprays versus their controller asthma med, things like that. So be very specific. Next slide. And this is the most important thing, and I think you have to practice this if you're not already doing it. And that's to phrase your questions assuming non-adherence. You want to let them know that it's okay for them to tell you they're not taking their medication. Not that you're happy that they're not taking them, it's that you want them to be honest with you, otherwise you don't know what you're working with. So you want to, instead of saying how often do you take your medication, it's better to ask them how often they miss medication, how often they forget their medication, and that assumes non-adherence. It presents that information in a more socially desirable way. So also couching it in a normative expectation I find helps. So when I talk to families, I say, you know, we expect patients to sometimes miss or forget their medications. I sometimes do. So during the last week, how many times did you miss or forget to use your inhaler? I'd challenge you, if you're not using this approach, to try to focus on using that approach, say, over a week with your clinic contacts and see if you don't notice people being more forthcoming in terms of their adherence levels. I think that it's a small change that can oftentimes lead to a big effect. Next slide. So now we need to move into treating non-adherence. And we're going to talk about strategies that fit into 4 categories: educational, organizational, motivational, and behavioral. Next slide. So we'll start with educational interventions. And it's important to note first that education is necessary, but it's not sufficient in promoting adherence in most patients. So simply providing the information does not necessarily improve adherence, and that's what research tends to pan out. But there are ways to suggest to improve our education to make sure that that foundation is there, because it's obviously the first and important step. Patients can't follow their regimen if they don't understand it. And what's been looked at in the literature is that it's been suggested that we use multiple methods when we teach our patients, that we provide them with written instructions, verbal instructions, use some modeling and role plays, maybe even do some problem scenarios. So what do you do if, and have them help to solve identify solutions to those kinds of scenarios, and providing them with feedback about their knowledge and their skills. And it's important to recognize that these educational interventions often occur when we get an initial diagnosis, but they really should be ongoing. They definitely need to occur when there's a change in a treatment plan, or when there's a change in who's responsible, like moving into adolescence, for example. So it's something that education needs to be not just a one-stop shop, but something where we actually continue to do it throughout the care of our patients. Next slide. Our communication approach is an important aspect of educational intervention, and the literature has shown that when providers use repetition, when they ask questions to assess the understanding of that the patients have and the families have, and use an empathic style when they communicate, there's better recall from the families. And one of these studies I actually completed myself, and asking questions was an important aspect of families having better recall of their treatment plan. You know, how often do you ask your patients to recall the instructions that you provide? Is that a routine practice for each of you in your clinic setting?
I usually try to, but they often have a very hard time remembering what they actually do. They say, what are we supposed to do? And like they're trying to tell you what they're supposed to do rather than what they actually do, and they don't remember.
I think the nurses do a very good job of that.
The nurses are
whenever
better
the
at
asthma
it,
action plan.
Right.
I think the asthma coordinator and I use a teach-back method. We have 4 basic questions just to review to see if they get it.
They get it, yeah. And, yeah,
Right.
It's like scenarios. It
Yeah.
says, what would you do if...
Scenarios. We do a lot of scenarios just to make sure that they're getting it.
Fantastic. You know, but a lot of clinics in the fast-paced setting, you know, I actually had a physician colleague who was told her pay was going to be docked because she was spending too much time with her patients. So, you know, sometimes it's viewed that we don't have the time to ask these questions, but building this somehow into our clinic routine, whether it's with a nurse educator or something, we really, as the literature does show, that taking the time to assess understanding is a key part of getting them to understand their treatment plan. Next slide.
Is that an option? You could get less pay and spend more time with your patients? I guess maybe that would... So maybe she should have...
That is a real situation. Yes, she was not happy about that. So, as you've heard me already hit upon multiple times, the provider-patient relationship is a key part of communication and education. Adherence is greater when you engage in a warm, friendly, and empathic manner rather than an authoritarian manner. The literature shows that consistently. When there's open lines of communication, when clinics can really facilitate some level of continuity of care so that the patients are seeing the same provider from visit to visit, has also been shown to be a key part of promoting adherence. And then keeping families satisfied, because the literature shows that parents and patients are satisfied with their medical care when are going to be more adherent. So, next slide. So when we educate, what's really been shown to be important is to get our patients to understand that there's a level of chronicity and variability in the asthma course. As many of you, I'm sure, can relate, a lot of our patients will have the pattern of we get them to buy in, take their medications, they take them, they get better, and then what do they decide?
Stop them.
I don't need my medications anymore. And they don't make that link that maybe the reason you perceive you don't need your medications anymore is because you were taking them and they were working, and it's something you need to continue to do. So really hammering home this important point of chronicity and variability and how that is the characteristic of asthma, and it's important to understand that so that they understand the rationale behind the medications that we prescribe, and to get them to understand why there's multiple medications as well. So it's an important aspect that we want to make sure they get communicated when they are being educated, and recognize that children in particular, and adolescents too, are at risk because they don't understand that the future consequences of non-adherence. They're more focused on the immediate consequences. So if I skip my inhaler or my treatment, I can actually run outside and play more. Those are the things they're focused on, so we need to make sure we recognize that. Next slide. So as you all talked about, asthma action plans are one of the ways that we've been sharing education with our patients and family. And the research does show that written asthma action plans are effective at preventing exacerbations when used in combination with self-management education. They help increase the confidence that caregivers have in handling their asthma episodes, and they show that the families feel like, again, they're more satisfied with the care and the education that they receive. Sadly, though, it's not common practice in all asthma clinics, but definitely not common practice in your primary care clinic. So that's an area I know Jay has worked on as well, and it's something that I think we need to continue to do. Providing written action plans may improve adherence. The literature is still a little iffy on that, but it's something that I think we need to continue to explore. Next slide. So when we look at asthma action plans, the literature shows that they need to be individualized. They need to be written and simplified. I have seen some action plans that are like reading an encyclopedia. And, you know, I think I wouldn't use it. So if I wouldn't use it, how are families with low literacy levels, for example, going to use it? So keeping them written is important, but making sure that what's in writing is simplified is important as well. Literature has shown that actually asthma action plans work better when they're symptom-based rather than when they're peak flow-based in terms of preventing exacerbations, so that's something to keep in mind. And including pictures can also be an important aspect. Next slide. So this is an example of a pictorial asthma action plan that was developed by another hospital. So it's an example of how you can use pictures to communicate rather than encyclopedia type entry of a written plan. Next slide. We also developed a pictorial asthma action plan when I was at Mercy, and it's something that we've gathered some pilot data on, and I look to actually submit a grant using this type of strategy and looking at adherence as one of the outcomes. So this is the green zone for that pictorial plan, and on the next slide you see the yellow and the red zone. So this is, you know, helping with families, hopefully, who may have low literacy rates or maybe have language barriers, but also I think it makes it, it's a one-page deal, even though it's on 2 slides, it's a one-page plan, and it might be something that could be posted, for example, in a place like the refrigerator or in the office where it can be used pretty quickly in the need of an emergency, for example. So it's something we need to look at further. Some organizational interventions that have been used are fairly simple, but not always feasible. But the literature has shown that supervising closely by healthcare professionals is an important way to look at improving adherence. Just increasing the frequency of contact alone can improve adherence. Not always feasible, but it's something that we should try to incorporate at least with our frequent flyers or our more severe patients. Doing things like simplifying the dosing schedule, minimizing the financial burden, as Jay alluded to, minimizing lifestyle changes, those are the kinds of things that we can do when we give our patients options. But we need to take the time to ask them about what it is that fits into their routine for us to prescribe the right type of device or the right type of medication. When we look at the literature and adherence, comparing different devices, the findings are actually mixed. And I think they're mixed because every patient and family is unique. So I don't think that one device is going to be necessarily better than another for everybody. It's probably that one device might be better for one patient while another device might be better for a different patient. So yes, if we ask their preference, that doesn't necessarily assume adherence, but it's a first step in looking at what's going on. And I like to use a case example here. I had a pulmonologist be really frustrated with a 17-year-old adolescent who came to his appointment on his own and basically was not using his inhaler, and told her he wasn't going to use his inhaler. When I went in and used a more patient-centered approach with him, I very quickly found out that he was in the choir. And he was using a dry powder inhaler that what he felt was affecting his voice quality. And all he needed was to be switched to a different kind of medication, but the nature of the interaction was not such that he felt comfortable sharing that with the provider. And it was such an easy fix. And we fixed it, and there was not an issue anymore. So simple kinds of things, but you have to talk to your patients, and you have to make them feel comfortable to tell you their circumstances and their preferences. The next couple slides I'm going to flip through pretty fast since we're kind of short for time, but motivational strategies are another way to look at improving patient adherence. And if you have an opportunity to attend a workshop or motivational interviewing, I would encourage you to do so. They're usually half-day or all-day workshops, and then they require a lot of practice in the end for using these with your patients. But it is an area, a newer area with asthma and other chronic disease with adherence, but it's something that's starting to show pretty good promise. The main thing is a lot of providers feel that this approach takes too much time, but the literature actually shows that no, it doesn't. It just changes, it doesn't change the length of your interaction with your patient. It just changes the nature and the quality of that interaction. So you're going to be looking at things like confidence, importance of change to them. Do they feel efficacious and prepared to make the change? Those are the kinds of things that are important. And again, health beliefs come into play here. If someone doesn't believe their disease is severe or their disease warrants medication, then they're not going to feel it's important to follow those kinds of treatment recommendations.
I was going to go back
Yeah,
here.
sorry.
Okay.
You ready?
Yep.
Okay, next slide. So way to do this is to really kind of assess the stage that the patient's in and work from there. And there are different stages from pre-contemplation where they're not ready to make any kind of healthcare change, all the way to maintenance where they've already made the change, and now that you just need to work on making sure that they consistently maintain that change, and the change would be adherence in this case. It's also important to ask permission to assist with them in helping to plan their health change. So things like, if you're interested, I have some ideas for you to consider on how we can get you to take your medications. Would you like to hear them? And why we ask permission is because it shows respect. It's actually a foot in the door technique. You're asking them to agree to something small, like to give them advice. And oftentimes we find that when people agree to small options, they're more likely to then agree to the bigger option, which in this case is the treatment plan. So just asking permission, for example, can be a really pivotal tool for getting patients to hear you and really try to follow what comes after that. And lastly, it's been shown that if you force a treatment plan on someone or force advice on them, that they're less apt to follow it than if they've accepted the choice to hear that advice. All right, next slide.
Mm-hmm.
So using a decisional balance or staging ruler are the techniques that are used here. And if you want more information on this, Jay, I can certainly send this to y'all. But you're asking them things like, what are good things about skipping your medications? And I've seen you do that actually, Jay, in some of your patient encounters. Oftentimes we do the opposite as providers. We ask them, what are the bad things that happen when they skip their medications? But actually, when you ask them what are the good things about skipping their medications, you're first off not being judgmental, and you're showing that, but you're also asking them to articulate their positive reasons, and you're getting motivation, you're getting ideas about what's motivating them to skip their medications. Then you ask what are the not, and then after that you ask what are the not so good things about skipping. You don't say bad things, because that's pejorative. You say the not so good things about skipping your medications. And so flipping that order can be a relationship enhancement approach that really can make the difference in the information you get from your patient. Then you want to ask them things like, on a scale of 1 to 10, how important is it for you to become more adherent? And then you ask them after they tell you, you take their number. Why did you choose 5 and not a 2? So again, you go reverse order here. Why did you choose a higher number? In other words, why did you say it's more important than less important? And there you're getting them to tell you positive reasons to be adherent, as opposed to the negative reasons. And then you ask, well, what's it going to take you to move from a 5 to a 7? And that's where you find out what their barriers are and their obstacles. So it's great ways, simple, but I have a cue card that I actually can share with you if you want. You can stick in your pocket and practice just doing one of these things for a week and then practice doing the other one for a week. to see again if it makes changes in the kind of information your patients provide.
That would be very good. And, yeah.
Okay, I'll be happy to do that.
Sometimes if they say that they're not going to be fully adherent but pretty adherent, sometimes that's good enough. If it sounds like maybe that's enough for them, is it okay to just kind of go along with them and say, okay, let's just be pretty adherent, instead of striving to make them perfectly adherent, which they're never going to be.
Exactly.
And that's true. You know, something's better than nothing. I work with cystic fibrosis as well, and as you all know, that regimen is huge. And, you know, I couldn't do it. And that's one of the first things I say. I have healthy, well-behaved kids. I can't imagine fitting that into my routine. And that's the first perspective we have to take to really understand. And so sometimes if we can get them to do 75% of it, or to prioritize the most important part for that patient and get that done, that's better than nothing at all. Whereas if we go in with the I expect perfection, we're beating ourselves against a brick wall, and they may do none of it. So it's important to recognize. So yeah, just to capture that, the motivational strategies, you need to voice confidence. You need to show enthusiasm. I'm confident that when you come to the time and you make a decision and you commit to this, I know you can do it. Those are the kinds of things that communicate empathy and a positive attitude. And I think if you take each one of those skills, like using the staging ruler, using the decisional balance, using just reflection with your patients and the way you ask your questions, if you can kind of target each of those one at a time until it becomes more of a habit, you'll find that overall you'll probably have a more positive interaction with your patient. It's just like any other habit. You know, we teach parents to spend 10 minutes a day doing nothing but praise their kids, and the purpose of that is to build a habit. You do things over and over and you focus on it, you get better at it. And these strategies are not what you're taught to do in medical school or nursing school. So you have to pick one and really focus on it till you feel like you've got it down, and then layer on another one and focus on it till you get it down. And in the end, I think you'll see that overall your interactions and exchanges with your patients will be much more informative than they probably were before. Family system is another area that is an important part of managing children's illnesses. We know families play a significant role, and as we talked about, it's important for parents to be involved. But it's also important for you to ensure that that parental involvement is supportive. Parents who are helicopter parents, who are highly anxious and controlling, that actually has been shown to be related to the conflict and non-adherence. So we want to make sure our parents are involved. We just don't want them to be involved in a negative fashion. Making sure our parents have good knowledge and problem-solving skills, and it sounds like you all have that in place, that you do question problem scenarios, and I think that's really an important step that a lot of clinics don't do. They just say, here's your treatment plan. And then the parents come home, and then they have a problem, and they're like, what do I do? You know, so really forward thinking about what are some of the problems these families will encounter, and then problem solving it in clinic can make huge steps towards doing the right thing once they get home. Stress and conflict are important to keep in mind and to recognize, and bottom line is that sometimes you need to refer these families to psychology, whether it's psychology, psychiatry, that if you don't, they're not going to get better. They're not going to follow the treatment plan. You know, if you've got a mother who's actively, you know, bipolar and, you know, obviously making sure she has the right education and motivation is probably not going to cut it. So recognizing that those kinds of families that have severe issues and severe dysfunction should probably be referred to address those issues while you at the same time look at the medical aspects of care. Next slide. So some behavioral interventions. You know, behavioral strategies really don't need to be complicated to work, especially if your family is motivated and willing and they're ready to push forward. Sometimes they just need some useful ideas for how to practically get better at doing their regimen and being more adherent. And we think some of it's common sense, but, you know, with a lot of families, it's not common sense. So things like using visual cues or reminders. They need to be salient reminders. They need to be put in strategic places. You know, I'm on a weight loss mission right now, and I have a picture of a really attractive woman taped to my mirror because that's where I am every morning. So I see it every day as a reminder. You know, people do habituate to things, but it is important to have reminders placed in an area where people are going to encounter them or to incorporate them into existing routines. I've had kids who are ADHD where I've recommended them wearing a watch where you can set an alarm at certain times that will beep so that they can remember to take their medications. Teaching them to self-monitor their medications. Sometimes, you know, families are wanting to be adherent, but they're just in a chaotic routine, and helping them to self-monitor. Or maybe there's multiple caregivers, like a divorced family, for example, and self-monitoring is the tool for enhancing the communication between those parents. And then, of course, problem solving. So if you flip to the next slide, I can show you some examples of these. So here's a sample monitoring form. Could be something that could be shared between divorced parents, for example, or just a way of keeping track of whether they use their medications or not. Or maybe if parents are allowing the adolescents to start using medications on their own, then this is a way that they could share a recording form to communicate that. Next slide. Here's a sample problem-solving worksheet. So just kind of making sure that the problem is defined and brainstorming solutions together, and then looking at what the pros and cons of those solutions might be before they decide what they're going to pick. Simple, we do it, but sometimes we need to teach families how to do it. Next slide. Sometimes just following things or problem solving isn't enough. Sometimes we need incentives or contracts, or as my mom likes to call them, bribes. I try to explain to her that no, they're not bribes, but that's what you will oftentimes hear from your families as well, is that, you know, using rewards and whatnot are bribes. But the bottom line is I use examples that we don't go to work unless there's rewards for us at work. A lot of times that's a paycheck for many individuals. You know, kids need rewards to motivate as well, and sometimes external motivation then leads to better internal motivation, and so that's one point to start. Relaxation training is also something that we can do. Imagery, progressive muscle relaxation, deep breathing. There are children who, when they start to feel an asthma exacerbation come on, start to become very anxious. And then it becomes to be a cyclical relationship, that anxiety then exacerbates the asthma symptoms, which in turn exacerbates the anxiety, and you can then sort of spin out of control. So teaching your patients some relaxation training, I'm going to give you just a real fast 101 explanation of that on one of the next slides, but that's an area that we can do. So sample behavioral contracts, here's just an example you can use, like a game board kind of strategy. You can do almost any kind of reward and contract. But this is a great example of using a game board where the child earns something, earns a check on a square when they do a certain target behavior, and once they've checked off so many squares, then they get rewards. The B actually stands for a bonus reward, I think, and then they get big prizes at different points. So you can pretty much make it up however you want. Next slide. So some basics of relaxation training. The two that I most often use with my asthma patients are belly breathing and imagery. Belly breathing, the key steps to that are to teach them to go in their breathe in their nose and exhale through their mouth, and that their belly should rise, not their chest. So you can have them put a hand on their chest and a hand below their belly button and practice and watch, and they should see their belly button hand raised much higher than their chest if they're really doing it in a relaxing way. And I'll show them that when you breathe in and raise your shoulders and inflate your chest, it's actually not relaxing at all, and demonstrate that for them. And then to slow down the exhalation, what I have them do is make a leaky tire sound, so or a snake sound. I don't usually use that because kids don't like snakes, but this kind of noise. And you can't exhale fast if you make that noise. You just physically can't do it. So it's a great way to teach them how to slow down that exhalation and get the full relaxation benefit from breathing. For imagery, I ask them to choose a positive and detailed scene and recognize that it doesn't have to be a beach. That's what it usually is for adults. But I use this picture here. I had a kid who walked through an amusement park was one of his scenes, and that was fine. Because really what you're trying to do is get them to focus on all 5 senses. Most people only focus on vision if they're not taught how to do imagery correctly. The enhanced way is to think about what you smell, what you hear, what you see, what you feel, what you taste. You know, you can think about it at the amusement park, tasting cotton candy, you know, the smell of corn dogs, or, you know, things like that. But you really want to focus on those senses and to slow down the trip. So don't go through the park real fast, but stay at one point of the park in your imagination and really experience everything that's around you through all your senses. If they do that, it's going to work in 2 ways. One, using your senses and slowing down makes that scene more real, makes it come to life in their head. And secondly, it uses up more of their cognition so that they're not thinking about the things that's making them nervous, like the asthma exacerbation. Sometimes with kids, I'll actually use visual aids as well, particularly kids who maybe haven't experienced a lot of positive places to visit, although I had one kid use his grandmother's house as one and would go from room to room in the house. So kids can be pretty creative, but sometimes you can use visual aids and go to a bookstore and get a travel magazine. I had a girl who was really into Celtic and Ireland stuff, and so she got an Ireland travel magazine and played Celtic music, and that's what she used with her imagery. Resources are available online for all these, for meditation, all kinds of relaxation tools are available. You can go to Amazon.com and download some, or encourage your patients to. Next slide. You can have them measure their tension ratings before and after on a scale 1 to 10, for example. You can have them monitor their use of albuterol in relation to that and see, for example, if there's a change that as their imagery or their relaxation improves, maybe their albuterol use decreases, for example, and show that to them as a data point. Next slide. And then in our behavioral interventions, we're starting to bring in more technology. Research is certainly at its, you know, junior or beginning level stage when we look at this, and we're chasing a constantly changing world with technology. But there are definitely studies out there that are ongoing now looking at web-based interventions, which is something I'm going to look into doing. People have used cell phones, sent alarms, text messages on the cell phones, or even allowed patients to purchase iTunes songs when they're adherent. Social networking is something that's being explored. There's really a number of ways that people are using technology now to enhance adherence. The Smart Inhaler is something I'm going to be using in my research. It's a device that comes out of New Zealand that measures adherence to the different asthma inhaler devices, but they actually also have a lot of neat web-based activities and web-based products to help provide feedback to family and to providers. So it's something that if you want, you may want to check out that link and see. They're a little costly, but again, if you've got a patient who's costly in terms of healthcare utilization, sometimes this is a nice alternative to consider. Next slide. We're getting towards the end here. So wrapping up, to address non-adherence in pediatric asthma, we have to first develop a really solid patient-provider partnership. We need to educate our patients and families and provide that education in writing, but be simple, and recognize that education should be ongoing. We need to assess and enhance motivation to adhere, and that includes making sure we understand that patients' and families' beliefs about their disease and their treatment, and to continue to address that in an ongoing manner as well. And then from that, we can develop some strategies and individualize those to the patients that we have to improve their adherence. So if you find out in your solid partnership relationship that the patient believes their disease, they follow their treatment plan, but they just have significant anxiety every time they have an exacerbation, then you know where your intervention needs to go. Always involve the family. Family is a pivotal part to the child being able to follow their treatment plan, whether they're the ones that are making sure it actually occurs for very young children, or whether the ones that provide the consequences to help promote positive behavior. You know, it really ranges the full spectrum, but families do need to be involved. And then follow up your plans. Find out did they work. Problem solve any conflicts or problems that you encountered or the family encountered with that plan. Next slide. So when we look at what interventions work, well, we need more research. We do know that behavioral and multi-component interventions tend to have moderate effects on changing adherence. When we look at educational interventions alone, they just don't have that kind of effect. So we really need to build in that multi-component by adding a behavioral or motivational component to the education, or using behavioral components to really help modify that adherence behavior. Next slide. And the conclusion is really the exceptional patient that adheres to a medical regimen, and that's the first thing we need to recognize. So we need to conceptualize the problem from that patient's perspective, reframe it from a deviance model to a more constructive, collaborative approach, and recognize that families each have their own different barriers, and those need to be identified. And they make their own complex decision-making process, and if you really have a good relationship with your patients and their families, you will hopefully be a part of understanding and taking part in that decision-making process so that adherence is negotiated, planned, and continues to be evaluated over time. That is it. Thank you.
Great. Thank you so much, Dr. Duncan, for this presentation. We really do appreciate it, and we'll certainly take all of your advice to heart. I would like to mention one final thing, and that is that you happen to be the last speaker in our 2011-2012 online conference series. So congratulations.
Oh.
You're finishing it up as our new series starts in July with the new fellows in our orientation series. So thank you so much for this presentation. We really appreciate it. Good luck on your research, and we'll look forward to talking to you again in the future.
Sounds good. Thank you very much. Have a good day.
So that's the end. Thank you all for joining us. This has been Conferences on Lyme Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. We will have a great weekend, everyone, and we'll see you next time. Thank you. Bye-bye.
Bye.
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.